we do need to move to segment 2. So I think, Tyler, let's queue up the poll question.
The poll question for segment 2, we have, does your state have a statewide working group to address sexual assault? Yes, no, or I don't know. The poll question, oh, there it is. Perfect. So once again, does your state have a statewide working group to address sexual assault? Yes or no? While all those are coming in, it is great to have such an excellent panel here with us today. We're coming around about 60% of our participation rate, and it's an overwhelming yes right now, at about 57% of the responses, about 5% saying no, and about 37% saying I don't know.
That's fantastic. I'm surprised the number is that high. I'm grateful that the number is that high. I think we'll probably get into some of the details of what those working groups look like or could look like if we really focused on that statewide working group and also the local community working groups. So I think we're ready for segment 2.
And so my role, that of the SANE and SART coordinator, actually originated with the ISAKI group. How did that come about?
It did. We were discussing, well, the ISAKI group discussed legislation every year. And for 4 or 5 years, there was successful legislation that went through to change things in Idaho. Everything from requiring all kits be tested, requiring an audit of kits, making sure that the victims didn't have to pay for their kits or for the collection to happen. Reforming insurance so that we didn't have issues with the private insurance being billed, that was covered so that we wouldn't have survivors or victims going to family members or having to account to family members for insurance issues. So there were a lot of things that were addressed. And one thing that was a mission, a critical mission of this group, was that we wanted to address our rural areas, our rural towns, where we knew that collection was not being done. One of the stories that came out in the newspaper and on the television stations was that we had a survivor that had to go from one of our rural areas 2 hours on a bus. They put her on a bus, a commercial bus, to send her down to the hospital in the Boise area to have a kit collected. Well, that wasn't acceptable to me or to anyone else on this group. And so we started to look at how can we set up SARTs in rural communities? How can we set up collection facilities in these rural areas? And so we initiated what was called SANE 250, which was that we wanted to train 250 SANE nurses in our state. We kind of looked at how many hospitals, how many areas we had, and that was a number that we arrived at that we felt would be a good number to address this in Idaho. But we realized quickly that we didn't have the resources to send these nurses to training, and we didn't have someone that could go, position by position, location to location to do this training. And it would be very costly for us to try and hire somebody from outside of Idaho to come in and do these trainings. So this group addressed that by thinking outside of the box a little bit, that we needed someone that could help set up these SART sites and also to coordinate the training that we knew needed to happen. We also wanted to see how we could set up this course, get it certified through IAFN, get it certified through a nursing organization to make sure that they were getting the credits that they needed to both be able to further their nursing career, but also to be able to take and sit for the SANE exam. And that was really our goal. So we quickly realized that someone was going to have to take on that role because none of us that were sitting on that group at the time had the time to administer that type of a program.
And it's been highly successful, I think. In a relatively short period of time, we've seen a number of big changes. Idaho is the 14th largest state in the nation, but the 13th least populous, meaning we're really spread out. We have only 55 hospitals in the entire state. Almost half of those, 25 of those, are critical access, so 30 beds or less, meaning staffing is always a challenge. We only have 10 hospitals that have 100 beds or licensed for 100 beds or more, and of course licensed doesn't mean that's their normal occupancy rates. So really getting someone out there, number one, to identify where kits were being collected and where they couldn't be collected, and what were some of those barriers with staffing there and education. Really, we've made a big change in that. This year alone, we have 4 new sites coming up collecting kits because we've been able to get out there and do that training, get that SANE A course out there for those places.
And that's so critical because if we have areas where we have survivors that don't have anywhere to go for resources, for healthcare. So some of our small rural areas, that's been a real blessing to have someone able to go there, physically go there and train their nurses. As you're well aware, it's really hard to staff the ER and other parts of the hospital. When you just don't have that level of staffing, it's tough to give anybody up. So being able to drive this training directly to them and be in their hospital offering this training to their nurses has been a huge benefit for this program. I'm just so grateful that we were able to find you that came in and kind of made this program their own, because that's really what we were looking for is, and we struggled greatly, honestly, to fill a position like this because SANE nurses they're a hot commodity. They are hard to come by in this country still. And so finding someone that had the level of skill of nursing that you had, also in administration that you had previously, was great benefit to us because you were able to administer the program, really grow the program, and get out into these rural areas to drive this training directly to them in their area.
Well, thank you. And getting there, once we got there, we were welcomed with open arms. These hospital administrators and the ER managers, one of the littler places I was just at, pulled all 5 of their ER staff to attend this 5-day training, meaning the manager and just people who don't very often work in their ER covered that to make sure that care was still provided in the community, but they got their staff there. And these nurses leave on fire to go back and say, yes, we can do this. They've always, of course, been a little stuck, either unfortunately putting that woman on a bus to get her there, which no one was comfortable with. Everyone knew that that wasn't the best thing to do, but they honestly just had no idea of what was available. It's kind of like not knowing exactly where all our kids were. We weren't even aware of what programs we had, who had formal programs, and we didn't have very many formal programs. Mostly people were just struggling to figure out what we needed to do, what the crime lab needed for evidence, and how to do that for their patients.
And when I look at the surveys that come back from you and from others on what they knew before and what they know after even a 40-hour course, it's astonishing. You go from 40% knowledge to 99% knowledge on some of the exams that they're taking. And so having that level of knowledge increase, it improves our evidence collection. It improves their level of care, both health care and trauma care for the sexual assault itself. And so I think it's critical in every state, and we recognized early that it was critical in our state that we take this training directly to them, not at a regional center, not at one center in our state, not across the country, but right in their hospital, right in their clinic, in their community. But we have made a huge difference in this issue in Idaho, that prosecutors, law enforcement, chiefs, sheriffs, individual detectives, patrol officers, all of these people coming together with victim advocates and others in the community right there where they live to recognize we have issues in our community, in our town, and they're addressing those now. It's not a statewide issue anymore, it's a community issue. We still will address it on a statewide basis. We will still offer resources. But addressing this right at the point of the problem is critical to the success of this in our state.
And I think that those communities are taking pride in the fact that they've recognized there's an issue here and that they are the ones with a little bit of resource, just a few questions answered sometimes is all that they need, but that they're stepping up and working together, forming those teams, not necessarily easily sometimes, but they're willing to stick with it, knowing that they're serving their community best that way. And I think that's how Idaho will always continue. I don't see us becoming the state big daddy who tells them how to do it. Rather, just provide those resources to help them identify what they need in each community.
I think there was some concern with your role or with our role as a statewide working group that we would be big brother, that we would come in and tell them how to do this. And I think they found the exact opposite. We come in with resources, we come in with guidelines. We've been very careful to call everything a guideline. We've followed a national protocol. We've followed NIJ directly with the NIJ working groups on this, with the SAFER working groups, making sure that we were centric to that first, making sure that we mirrored that, and that we even went beyond that for best practice in our state, making sure that everybody weighed in, making sure everybody had visibility on what the guidelines were, making sure that they could implement the guidelines in their hospital, in their clinic, in their community. So I think that's been critical. But I think also the approach that we've taken in The state will come in, will train, will help, will offer resources, but we are not Big Brother.
And that's been one of the most fun things that I've done, is forming the Idaho SANE Program Leaders Group, or the ISPL I call it, where the leaders of these organizations, whether it's the ER director, whether it is someone who is in a justice center, can really get together, and to see them begin to talk and have Salmon, for example, say, well, you know, we're so small, but we're going to bring this up, and Idaho Falls saying, hey, I've got policies I can share with you, and I've got this. And so it's really been fun to sit back and watch that networking and help foster that sometimes, but really see, and that's how we know that this will continue. And that when I first came on, we didn't even know where all of our programs were, as I mentioned a little earlier. Now people know. Not only did we not know at the state level, no one across the state knew. And now people know each other, and they know where they can call. If they don't reach me, or they just want to talk to another program manager, they know where they can call to get some help.
That networking component is critical. And like you had mentioned, we had a reporter, I believe, call us and say, can you tell us how many centers you have, what their hours are, what their capabilities are? And we quickly realized we have no idea. And so doing some of that work, that detective work, to find out where are these centers and what are their hours and what capabilities for collection do they have, and setting up that group that you set up to allow us to do some of that networking has been critical as well. I look forward to the time when we have the website set up that we're working on to identify those resources for the survivors of these crimes, that they know exactly where they can go and where the safe places are to have a kit collected, but also they know what their hours are. They know when they can go and when they're available, and contact phone numbers and information. But I think that networking component, both in the statewide working group and also in the SANE Leader program, that has been critical for them to share information with each other. We can share all we want, but when it becomes a peer-to-peer, it becomes a much different resource.
And with that, we're going to enter into another section for discussion. Matthew, the mic is yours.
Thanks, Tyler. I want to bring in Carl Noah. Carl was one of the ones that came in very early. He's, again, a lieutenant with the Bonneville County Sheriff's Office here in Idaho. Carl, tell us a little bit about why you became interested in working on ISACI, why you were interested in participating in the statewide working group, and what it's done for you over the years that you participated with us.
Thank you, Matthew. For me, part of it was getting the connections for everybody else across the state. I've worked with Angela over the years and Tina, and just getting the broader picture of what we can do and where we're going with it. And then having the center on board was great, because then we're getting, where are we going, getting more funding, because in my opinion, the state lab needed more funding back then, very specifically toward DNA. And then what it's done for us it's given us more nurses that are trained. It's given us places where I can send detectives to have more training, specifically the trauma-based informed training, and just to have basically all the connections up and down the state. And also for us, Boise works on kind of like one model. We work on another model, and you got Northern Idaho. So we're very rural in certain places, and other places more populated. So everybody does things a little differently. So if you share that, I think we come up with a better working group across the state to make sure we're kind of doing things roughly the same way.
I'm glad you brought that up, because that was a consideration. We wanted law enforcement from various county, city, other jurisdictions. So we have added that to our working group. You represent maybe a little bit more rural community there in Bonneville County. Maybe bring in Angela Weeks here. You're part of the Boise area, which is a little bit more metropolitan area. Why were you interested in participating from law enforcement perspective?
For me, it is about collaboration. I always think that when we work together with others, there's more that we can gain and the more benefit that we have for the victims that we serve. So if we're collaborating with other law enforcement, because we know our victims don't just stay in our jurisdiction. We know that they experience being served by other communities, by other professionals, and that collaboration to make sure we all have a standard of care that applies to our victims was really crucial for me. And I had been involved in a lot of training opportunities and just different things, in the state and across the country, and just being able to be part of that conversation. And it was also important for me to make sure that group had a law enforcement voice of somebody who was out working in the field and knowing what it was like, when if a victim wasn't returning calls or trying to get hold of suspects or, getting things turned in a certain amount of, time frames. I just wanted to make sure that those voices were being represented at the table.
And those voices have been so important for us to hear. A lot of things we will talk about kit retention, and Chief Kingsbury will talk about kit retention later on in the presentation. That was really important that law enforcement was at the table when we're making decisions that will directly impact them and their property rooms. And that was a great discussion that we had. I remember sitting around the table with all of the different stakeholders. And one of the things that we originally set up this ISACI working group for was this concept of a survivor having to get on a bus in rural Idaho, be driven to a metropolitan area, and that's not acceptable to any of us. I remember having those discussions with the legislature and with other stakeholders. That wasn't acceptable to us. So one of the questions coming in the pod from Paul was about mobile exam facilities and other things that we're doing to address remote locations. Deb, what are we doing there?
We are doing some different things. We have a couple of the different programs in the state that the nurse actually goes out and may cover 5 or 6 different hospitals. And so we have another private industry, another private organization that provides the same nursing, and she actually covers 6 counties and will go to different places. So we'll go out to the patients. We have a child advocacy center in the state that is looking at putting together an actual mobile bus that can be driven anywhere across the state to do pediatric exams. So we have some mobility, and certainly it's something that we're looking at more of because of the ruralness. When you get the weather like we're having sometimes now and some of the snow, it's really hard for victims to go just logistically, but emotionally it's a lot harder. And so we know that it's important that we go to the victim.
We set up the SANE 250 initiative, which was to train 250 SANE trained nurses, not SANE certified nurses, but at least having been through the 40-hour course to do evidence collection. And we focused on our rural communities. Tell me a little bit more about how that's going.
It's going really well, although when I talk to some of the other state coordinators, I get a little jealous when they say that they have up to 50 nurses in a course. I'm doing a course actually in February that I have 2 nurses and 2 advocates signed up for, and I'm very willing to do that. Probably our average number of students per class is about 5, but it's getting out and going to those rural hospitals, to those rural areas, and working with the staff that they can afford to take away from the bedside. And we know that it's going to take us longer to get that done. That's okay. We're just going to keep chipping away at it. But we do also have a stopgap measure where I can come out to emergency rooms and have a short 4-hour course that really says, when you don't have a SANE nurse available, this is not an effort to replace SANE nurses or say that you don't need SANE nurses, because you really need SANE nurses. But we do have a 4-hour course for ER staff to say, when you are the only one and that victim walks in the door, here's how you take care of her.
Now, we've talked a lot about rural nursing, and I could get the numbers wrong here, but what I remember is we have 9 courses set up next year around our state in these local rural communities. You physically drive there, you physically teach these courses at the hospitals where these nurses work. And then I believe we said we had 5 or 6 new programs, new collection programs started at rural hospitals last year.
Yes, we did. The nurses came, and sometimes just 1 or 2 nurses from a site, and said, yeah, we can do this. We're going to take this back, and are doing that. And they have. And that networking from the ISPL, and they know that they can call me at any time. I've actually had 2 nurses now call me and say, Deb, I took your course and now I've got a patient here and I'm not sure what to do. Can you help me? And I've been able to actually help walk them through that exam in real time. So they're getting out there, they're doing it. It's really exciting to see the dedication, because it is dedication. It's hard work and it's a sacrifice. Number one, these nurses work full time doing something else, either work in the emergency room or they work in labor and delivery. And they're taking the same nursing in addition to that. And so that's a lot of extra time and effort. but they want to do that for their communities.
Now, our time is short, but I want to take this last question coming from Stephanie, because I
Okay.
think it's important for what we're going to talk about next. And that is, talk to me about SANE A. What does that mean? And what about SANE P?
Excellent question, Stephanie. It's one we certainly have recognized. SANE A is a sexual assault nurse examiner for adults and adolescents. So there is some coverage over to the pediatric, but it does not cover pediatric. And because of the way my position is funded at this point in time, I am limited to teaching just the SANE A course. That doesn't mean that our peds aren't being taken care of. We actually have one program in the state that is developing a combined SANE A, SANE P, just because they're creating a forensic nursing department. I'm really excited about this. It's the first one in the state. We do not have any program in the state that has 24/7 coverage, even utilizing call for SANEs. And this department in Northern Idaho is going to change that. And so what they have recognized is that they need a combined SANE A, SANE P course. We do have some other SANE Ps that have been trained elsewhere that are functioning in some of our programs. So although I'm not going to say that we have peds covered as well as we would like, because we don't, but we're looking at that. Once my funding limitations are changed, then I will also become certified as a SANE P, and ISP will begin to offer those as well.
We're looking at that funding in the legislature this year. I think one of the important things to acknowledge here is we don't have all the answers. We've experienced some of the pains, and we've addressed some of the questions, but we still have room for improvement, and we're looking for all of your ideas too. So please continue to engage with us in the discussion pod, ask those questions that you have, offer suggestions that you have. Again, this is a peer-to-peer event. So with that, Tyler, I think we're ready to move on to our next video segment.